Sudden cardiac arrest, BRUGADA syndrome. Carlo Francisco Escochuico, MD. August 14, 2008. Objectives to present a case of sudden cardiac arrest in a young male. To discuss the approach and management of BRUGADA syndrome, general data. JD 28-year-old male Filipino chief complaint. Loss of consciousness. History of present illness. 1 hour PTA. Found unconscious. Seen with upward rolling of eyeballs, stiffening of extremities, and salivary pooling. Lasted 3 to 5 minutes. Regained full consciousness with no recollection of the incident. Was able to drink, sit on a chair, and talk with parents. No slurring of speech, no extremity weakness, no chest pain. History of present illness. 5 minutes after. Recurrence of stiffening of extremities and upward rolling of eyeballs. Rushed to MMC ER. During transit, he remained unconscious. Events at ER. Quick look showed cyanosis PP0HR0Gs3E1V1M1. Initial tracing at ER at 1:42 am. Chest compressions and bag mask ventilation. Defibrillation at 200 joules. Epinephrine 1 mg for. Intubated and advised ICU admission. X-ray, Stat5 and ABG. 12 liters EKG the 8th of January 2008 2:16 am post defibrillation CRBBBPR interval 0. 12 liters EKG the 8th of January 2008 2:16 am post defibrillation CRBBBPR interval 0.16 seconds QT interval 0.36 seconds. Events at ER 2:33 am at ER systolic PP 170 pulsate is regular. Post CP arrest. Events at ER 2:47 am episode of stiffening of extremities. Chest compression and defibrillation at 200 joules. Events at ER 2:52 am post defibrillation BP 120/80 pulsates. Amiodarone drip started. Cardiac enzymes. Referred to neurology. Admitted to ICU. Review of systems general, no fever, fatigue, weight loss. Skin, no rashes, jaundice, ecchymosis, petechiae. Head, no recent head injury, headache, dizziness. Eyes, no blurring of vision, redness, pain. Ears, no tinnitus, vertigo, earache, discharge. Review of systems nose, no colds, nasal congestion, discharge. Mouth, no sore throat, hoarseness. Neck, no pain, lumps, mass, stiffness. Respiratory, no cough, dyspnea, wheezing, hemoptysis. Cardiac, no chest pain, palpitations, orthopnea, PND, edema, recent chest trauma. Review of systems. Gastrointestinal, no nausea, vomiting, regurgitation, dysphagia, hematemesis, abdominal pain, change in frequency and characteristic of stools. Urinary, no hematuria, dysuria, oliguria, polyuria, urgency, hesitancy. Vascular, no claudication, varicose veins, leg cramps. Musculoskeletal, no myalgia, arthralgia, and swelling. Review of systems. Hematologic, no anemia, pallor, easy bruising or bleeding. Endocrine, no heat or cold intolerance, no excessive thirst or hunger. Psychiatric, no depression, nervousness. Parsed medical history, no history of HPN, DM, and BA. PTB, treated for 6 months. No previous seizure disorder, no known neurologic and cardiac problems. Had a history of syncope during early childhood and another one a year ago, no workups were done. Family history, plus, HPN in paternal side, DM, BA, stroke, cancer. No seizure disorder, personal and social history. Occasional smoker. Occasional alcoholic beverage drinker. Denies illicit drug use. Physical examination conscious, restless, intubated. BP 120/80 HR80 regular RR20 assisted or febrile. Warm moist skin, no active dermatoses, no jaundice. Anopteric sclerosis, pink palpebral conjunctiva, pupils 2 to 3 mm ERTLOU. No visible anterior neck mass, no neck vein distension, no carotid bruit. No cervical lymphadenopathies. Physical examination. Equal chest expansion, no retractions, no rales, wheezes, crackles. A dynamic precordium, about fifth lixims, regular rhythm, S1 greater than S2 at percent, S2 greater than S1 at apex, no extra heart sounds, no murmurs. Abdomen flabby, normal active bowel sounds, soft, no guarding, no direct and rebound tenderness, no hepatosplenomegaly. No costovertebral angle tenderness. No pedal edema. Pulses full and equal. Physical examination G11E4V1, intubated, M6 no pupil edema. Full and equilium. No facial asymmetry. Intact doll's eye movement, gag and corneal reflexes. Direct tendon reflexes normal. Motor and sensory, intact. Localizers to pain and temperature. No Babinski, Koenigs, and Brudzinski. Salient features 28M Filipino. Loss of consciousness at night during sleep. 2 episodes of stiffening of extremities. Post-CP arrest 2X, fib. No fever, headache, chest pain, weakness. History of syncope 2X. Positive family history of cardiac disease. No illicit drug use. Differential diagnosis. Differential diagnosis. Differential diagnosis. Differential diagnosis. Structural heart diseases. Ischemic heart disease. Non-ischemic cardiomyopathies. Valvular heart diseases. Arrhythmogenic right ventricular dysplasia. Primary electrophysiologic abnormalities. Long QT syndrome. BRUGADA syndrome, ischemia. Cardiac arrest due to ventricular arrhythmias may be due to chronic scar or to acute ME/ischemia. A chronic infarct scar can serve as the focus for reentrant ventricular tachyarrhythmias. Non-ischemic cardiomyopathies represent the second largest group of patients who experience SCD. Dilated cardiomyopathy is usually characterized by ventricular dilatation, initially usually of the left ventricle, LV, with myocyte hypertrophy and diminished systolic function. Hypertrophic cardiomyopathy, HCM. An autosomal dominant, incompletely penetrant genetic disorder resulting from a mutation in one of the many, greater than 45, genes encoding proteins of the cardiac muscle sarcomere. Echo of HCM. Small LV cavity due to marked hypertrophy of the myocardium and encroachment into the LV cavity. Reduced septal motion and thickening during systole, particularly of the upper septum, due to the disarray of the myofibrillar architecture and abnormal contractile function. Reduced rate of closure of the mitral valve in mid-diastole due to a decrease in LV compliance left atrial enlargement. Course in the ward. First hospital day in the ICU, 1230 p.m. Repeat 12 liters EKG done. RSR pattern. Saint elevation in lead V1 V3. 2D echo, NLVDEF 69% normal LA and RA dimensions. Normal MV, TV, avenue, PV. Mild Mr. TR. Normal left ventricular diastolic function indices. VO2 adjusted to 0.35. Course in the ward ICU at 1500 HTPs placed and repeat ABG done. Referred to cardiology EPS. Thyroid function test requested. Quinidine bisulfate started. Course in the ward ICU at 1750 H. Patient extubated 4th hospital day. Transferred to regular room. Quinidine 200 mg/tab adjusted to 1.5 tablets in the morning and evening, and 1 tablet at lunchtime. Course in the ward 5th hospital day, repeat 12 liters EKG. Normal. Discharged on 6th hospital day. Follow-up after 1 week. X-ray August 1, 2008. Lungs are clear. Heart is magnified. ET in place with tip at carina. Cranial CT scan August 1, 8th. Normal non-contrast CT of the brain. EEG. Normal. 2D echocardiography August 1, 2008. Normal left ventricular dimension with normal wall motion and contractility. Computed LVF 69%. Normal left and right atrial dimensions. Normal mitral, aortic, tricuspid, and pulmonic valves. Mild Mr. TR. Normal left ventricular diastolic function indices. Repeat 12 liters EKG the 8th of January 2008 12:30 p.m. BR interval 0. Repeat 12 liters EKG the 8th of January 2008 12:30 p.m. BR interval 0.16 seconds QT interval 0.40 seconds. Laboratory results and ancillary procedures. CBC HGB 16.8 HCT 50.2 WBC 14.21 SEG 54 Lymph 36 EOS 4 Mono 5 BSO 1 Platelet 2,40,000 Stat 5 NAR 137 K 2.7 HGB 16.7 HCT 49 Glucose, random 245 mg/dl. Laboratory results and ancillary procedures. Cardiac enzymes. CK total 165 UL. CPK MB 1.4 nanograms per milliliter. Troponin I 0 nanograms per milliliter. PTT. Patient 27.3. Control 27.6. PT. Patient 11.1. Control 11.7. Activity 115.6%. 94 Indian paise. Laboratory results and ancillary procedures. Spec 23. NAR 137. K 3.6. CL 103. Calcium 9.78. BUN 13. Creatinine 1.1. HDL 46. Trig 119. LDL 166. Cholesterol 245. Glucose 120. CPK 506. LDH 262. ALT 185. AST 82. Alkaline phosphatase 148. Laboratory results and ancillary procedures. Routine urinalysis. Yellow hazy. pH 6. SPJR 1.020. +3 protein. Trace sugar. Negative ketones, nitrites, leukocyte esterase. +1 blood. RBC2/HbF. WBC2/HbF. EPIT10/HbF. BACT15/HbF. Thyroid function test. TSH 0.037, 0.27 to 3.75. FT3 4.419, 4.2 to 12. FT4 17.815, 8.8 to 33. Laboratory results and ancillary procedures. ABG. Post-intubation. PO2 426.2. pH 7.34. PCO 241. HCO 322.1. O2 SAT 99.8. AC mode 100% FiO2 VT 420. Laboratory results and ancillary procedures. ABG. 5 p.m. PO2 169.1. pH 7.39. PCO2 37.3. HCO 322.5. O2 SAT 99.1. Inline neb via TPs 35% FiO2. Repeat 12 liters EKG the 8th of June 2008 9:54 am normal PR interval 0. Repeat 12 liters EKG the 8th of June 2008 9:54 am normal PR interval 0.20 seconds QT interval 0.44 seconds. Discussion. Sudden cardiac death, SCD, is an unexpected death due to cardiac causes, heralded by loss of consciousness occurring in a short time period, generally within 1 hour of symptom onset. Most cases are due to cardiac arrhythmias such as VF or VT, which is responsible for 50 to 80% of cases. Sudden cardiac death. Most cases of SCD occur in patients with structural abnormalities in the heart, related to either prior MI, coronary artery disease, cardiomyopathies. Valvular diseases such as aortic stenosis are associated with increased risk of SCD. Acute inflammatory and infiltrative disorders, such as myocarditis, provide a sustained risk of SCD. Sudden cardiac death. Less commonly, SCD happens in patients who may not have apparent structural disease. These conditions are usually inherited arrhythmia syndromes or primary electrophysiologic abnormalities. Primary electrophysiologic abnormalities. This generally represents a group of abnormalities in which patients have no apparent structural heart disease but have a primary electrophysiologic abnormality that predisposes them to VF or VT. BRUGADA syndrome, long QT syndrome. BRUGADA syndrome. A cardiac disease caused by an inherited ion channelopathy associated with a propensity to develop ventricular fibrillation, VF. Reported as early as 1953 but was first described as a distinct clinical entity associated with a high risk of sudden cardiac death in 1992. BRUGADA syndrome. In the 1980s, the Centers for Disease Control and Prevention reported a high incidence of sudden death in young immigrants from Southeast Asia. For natives, it is known as Laita, death during sleep, in Thailand, Bangangat, sudden death during sleep, in the Philippines, and Pokuri, unexpected sudden death at night, in Japan. BRUGADA syndrome. Familial disease with an autosomal dominant mode of transmission, with incomplete penetrance and an incidence ranging between 5 and 66 per 10,000. In Southeast Asia where it is endemic, it is distinguished by a male predominance, 8:1 male-female ratio, and the appearance of arrhythmic events at an average age of 40 years, Runge 1 to 77 years. BRUGADA syndrome. The syndrome typically manifests during adulthood, with a mean age of sudden death of 41+/15 years. The youngest patient clinically diagnosed with the syndrome is 2 days old and the oldest is 84 years old. BRUGADA syndrome, report of the Second Consensus Conference Circulation 2005. BRUGADA syndrome. It is thought that it may cause 4 to 10 sudden deaths per 10,000 inhabitants in Southeast Asia annually, making it the second most common cause of natural death in men aged younger than 40 years. In endemic countries, it has been estimated to cause at least 4% of all sudden deaths and at least 20% of all sudden cardiac deaths in patients with structurally normal hearts. Orphanage Journal of Rare Diseases 2006. BRUGADA syndrome. The prevalence of BRS in the general population is unknown. The suggested prevalence ranges from 5/1000ths, Caucasians, to 14/1000ths, Japanese. In Laos, it causes an estimated 1 sudden death per 1,000 inhabitants per year, and in Thailand, unexpected sudden death is the most common cause of natural death in young people. BRUGADA syndrome. It has been linked to a genetic mutation located on the SCN5A gene on chromosome 3p21.23, which codes for the alpha subunit of the cardiomyocyte sodium ion channels. This mutation leads to either complete loss of channel function or an accelerated recovery from activation. This can generate heterogeneity of repolarization and increase the chance of intramyocardial reentry circuits, which may induce ventricular tachyarrhythmias. Genetic mutations detected so far in the BRUGADA syndrome result in defective myocardial sodium channels that reduce sodium inflow currents, resulting in shorter than normal action potentials. BRUGADA syndrome. It can also present atrial fibrillation, which is present in 10% to 20% of cases. Potential clinical manifestations: dizziness, palpitations, syncope, and sudden cardiac death. ECG abnormalities constitute the hallmark of BRUGADA syndrome. Circadian pattern. VF and sudden death in BRUGADA syndrome usually occur at rest and at night. Modulating and precipitating factors. The ECG manifestations of congenital BRUGADA syndrome are often concealed but can be unmasked or modulated by sodium channel blockers, a febrile state, vagotonic agents, alpha and beta adrenergic agonists, tricyclic or tetracyclic antidepressants, a combination of glucose and insulin, hyperkalemia, hypokalemia, hypocalcemia, and alcohol and cocaine toxicity. BRUGADA syndrome electrocardiographic characteristics. The J wave is a deflection that appears in the ECG as a late delta wave following the QRS or as a small secondary R wave, R, also referred to as the Osborn wave. BRUGADA syndrome electrocardiographic characteristics. Type 1 is characterized by a prominent coved Saint segment elevation displaying J-wave amplitude or Saint segment elevation 2 mm or 0.2 mV at its peak, followed by a negative T wave, with little or no isoelectric separation. Proposed diagnostic criteria for the BRUGADA syndrome, Consensus Report Circulation 2002. BRUGADA syndrome. BRUGADA syndrome electrocardiographic characteristics. Type 2 also has a high takeoff segment elevation, but in this case, J-wave amplitude, 2 mm, gives rise to a gradually descending Saint segment elevation, remaining 1 mm above the baseline, followed by a positive or biphasic T wave that results in a saddleback configuration. Proposed diagnostic criteria for the BRUGADA syndrome, Consensus Report. Circulation 2002. BRUGADA syndrome electrocardiographic characteristics. Type 3 is a right precordial Saint segment elevation of 1 mm of saddleback type, cove type, or both. Proposed diagnostic criteria for the BRUGADA syndrome, Consensus Report. Circulation 2002. BRUGADA syndrome. Proposed diagnostic criteria for the BRUGADA syndrome, Consensus Report. Circulation 2002. BRUGADA syndrome, Report of the Second Consensus Conference Circulation 2002. It can be established in the presence of Saint segment elevation, type 1, in more than one right precordial lead, V1 to V3, and one of the following. Documented ventricular fibrillation, self-terminating polymorphic ventricular tachycardia, a family history of sudden cardiac death, less than 45 years, cove-type ECGs in family members, electrophysiological inducibility, syncope. There should be no other factors that can account for the ECG abnormality. BRUGADA syndrome, Report of the Second Consensus Conference. Appearance of type 2 Saint segment elevation, saddleback type, in more than one right precordial lead upon challenge with a sodium channel blocker. A drug-induced Saint segment elevation to a value greater than 2 mm should raise the possibility of BRUGADA syndrome when one or more clinical criteria are present. BRUGADA syndrome, Report of the Second Consensus Conference. Appearance of type 3 saint segment elevation in more than one lead under baseline conditions with conversion to type 1 after challenge with a sodium channel blocker is considered equivalent to case 1 above. Drug-induced conversion of type 3 to type 2 is not considered diagnostic. Characteristic EKG morphology is recorded within the first few hours after resuscitation cannot be taken as diagnostic. Drug challenge. Drug challenge should be performed while the patient is continuously monitored and with defibrillator and advanced coronary life support facilities close at hand. Drug administration should be stopped when the test is positive and/or when ventricular arrhythmias, including ventricular premature complexes, are evident, or when significant QRS widening, 30%, is observed. Type 2 and Type 3 ECGs, the test is recommended to clarify the diagnosis. Conversion of a Type 2 or 3 ECG to a Type 1 is considered positive. Proposed diagnostic criteria for the BRUGADA syndrome, Consensus Report Circulation 2002. Differential diagnosis. Acute myocardial ischemia. Acute myocarditis. Tricyclic antidepressant overdose. Cocaine intoxication. Arrhythmogenic right ventricular dysplasia. Long QT syndrome. Arrhythmogenic right ventricular dysplasia. Discrimination between BRS and SRVC may be particularly difficult because ARVC may at times mimic PRS. Before the diagnosis BRUGADA syndrome is made, a serious attempt should be taken to exclude SRVC. Drug challenge with sodium channel blockers may be useful in discriminating between these two diseases. Proposed diagnostic criteria for the BRUGADA syndrome, Consensus Report Circulation 2002. Long QT syndrome. There is an alteration in the function of a myocellular channel protein that regulates the potassium flux during electrical repolarization. Clinical cause is variable, some remain symptomatic and some develop syncope and sudden death. Risk is impacted by factors such as hypokalemia, emotional extremes, and vigorous physical activity. Long QT syndrome involve an abnormal repolarization of the heart causes differences in the refractoriness of the myocytes leading to re-entrant ventricular arrhythmias. Long QT syndrome. A commonly used criterion to diagnose LQTS is the LQTS diagnostic score. It's based on several criteria giving points to each. With 4 or more points the probability is high for LQTS, and with 1 or less point the probability is low. 2 or 3 points indicates intermediate probability. Long QT syndrome. QTC, defined as QT interval, square root of RR interval, greater than equals 418 sec, 3 points. 460 to 417 sec, 2 points. 415 sec and male gender, 1 point. Torsade their points ventricular tachycardia, 2 points. P-wave alternans, 1 point. Notched T-wave in at least 3 leads, 1 point. Low heart rate for age, children, 0.5 points. Syncope, one cannot receive points both for syncope and torsades their points. With stress, 2 points. Without stress, 1 point. Congenital deafness, 0.5 points. Family history, the same family member cannot be counted for LQTS and sudden death. Other family members with definite LQTS, 1 point. Sudden death in immediate family members before the age 30, 0.5 points. Long QT syndrome. Long QT syndrome. Beta blockers are the first choice in treating long QT syndrome. The only effective form of arrhythmia termination in individuals with LQTS is placement of an implantable cardioverter defibrillator, ICD. ICD are commonly used in patients with syncopes despite beta blocker therapy, and in patients who have experienced a cardiac arrest. BRUGADA, risk stratification. BRUGADA et al. Found that patients initially presenting with aborted sudden death are at the highest risk for a recurrence, 69%. Those presenting with syncope and a spontaneously appearing type 1 ECG have a recurrence rate of 19%. Men had a 5.5-fold higher risk of sudden death than did women. BRUGADA syndrome indication for ICD implantation. BRUGADA syndrome report of the Second Consensus Conference, endorsed by the Heart Rhythm Society and the European Heart Rhythm Association. BRUGADA syndrome indication for ICD implantation. BRUGADA syndrome report of the Second Consensus Conference, endorsed by the Heart Rhythm Society and the European Heart Rhythm Association. Outcome after implantation of a cardioverter defibrillator in patients with BRUGADA syndrome, a multi-center study, Circulation 2006. In this large BRUGADA syndrome population, a low incidence of arrhythmic events was found, with an annual event rate of 2.6% during a follow-up of 3 years. Device-related complications, 8.9%/year. Inappropriate shocks were 2.5 times more frequent than appropriate ones. It prevented VF induction in 22 of the 25 patients, 88%. Efficacy of quinidine in high-risk patients with BRUGADA syndrome. Bernard Bellison, Maryland, Aher and Glick, MD, Sammy Viskin, MD. Circulation 2004. Quinidine depresses ETO current, which may play an important role in the arrhythmogenesis of this disease. It prevented VF induction in 22 of the 25 patients, 88%. The effective quinidine serum blood levels ranged from 1.29 to 5.2 mg/L, means, to 650.99 mg/L. Quinidine may exert its beneficial effects in BRUGADA syndrome by inhibiting ETO, thereby restoring electrical homogeneity. In addition, quinidine prolongs ventricular refractoriness. Finally, the anticholinergic effect of quinidine might contribute to its antiarrhythmic efficacy in the BRUGADA syndrome. Despite these hypotheses, the basis for quinidine efficacy in this setting remains to be elucidated. Study shows the following. First, quinidine is highly effective, 88% success rate for preventing VF induction in patients with inducible VF. Second, it also appears to be effective in preventing spontaneous VF, with no arrhythmic events observed during a mean ST follow-up of 56 to 67 months. Third, the drug could be chronically tolerated with therapeutic effectiveness in 16 study patients, 64%. Fourth, no proarrhythmic event occurred in any treated patient despite QT prolongation. Finally, although quinidine-related side effects, thrombocytopenia, diarrhea, esophagitis, allergic reaction, aggravation of sinus node dysfunction, were common, they were always transient and invariably resolved after drug discontinuation.